I want to introduce Dr. Maureen Nash. Dr. Nash is going to speak to us today on the assessment and alleviation of suffering in people with end-stage dementia, a topic that not too many others are experts in, so we're grateful to have Dr. Nash today. Please use the chat box for questions, and know that we will hold questions until the end of the presentation unless Dr. Nash decides herself that she'll chime in. But otherwise, know that we're seeing your questions as they come in. We're not ignoring you. We're just going to make sure she has plenty of time to get through her material. So on that note, I'd like to turn this month's Gero Ed Hour over to Dr. Maureen Nash. And thank you, Dr. Nash.
Hi, everybody. I'm going to start out just with a description of Bob. And he's sort of a typical person who we might be talking about today. Bob's 84. He was referred to a geriatric psychiatry unit for severe aggression. He has very advanced dementia. He has lost 25 pounds over the last 3 months. He's not really interested in eating. He doesn't speak very much. And when I was doing a care conference with the family, I was talking about Bob's dementia and how he was nearing the end of life. And this was a shock to his family, to his wife and his children who were at the care conference. No one had ever told them that dementia was a fatal progressive illness. And that was a little bit of a shock to me. But since that time, I've discovered that it's quite common. And I think some of it is primary care providers don't necessarily have a robust ability to diagnose dementia. I think they actually have more capacity than they may think they have. And I think people don't have a good picture in their head for what advanced dementia looks like and what the end of life might look like if they haven't seen it many times. And so I think those are two of the issues. And frankly, I think people just don't talk very much about dementia. I think it is such a scary topic that lots of times people avoid talking about it at all. So today I am going to talk about dementia as a terminal illness. I'm going to talk about some of the ways that that might look. I'm going to review two specific tools, the PAIN AD or Advanced Dementia Scale and the Mini Suffering State Exam. I'm going to review behavioral symptoms or neuropsychiatric symptoms related to dementia, and I'm going to sort of help people conceptualize, hopefully, which symptoms are best managed with caregiver training and which symptoms are best managed with both pharmacological interventions, medications, as well as caregiver training. And I am going to do a very brief review of appropriate use of dementia-specific medications. So Alzheimer's dementia is quite common, and it is increasingly becoming one of the most common causes of death in the United States. It's actually the only cause of death that is increasing because we don't have any disease-modifying treatments, and because of all of the disease-modifying treatments we have for other things. We can treat heart disease and prostate cancer and breast cancer and stroke and HIV far more than we used to be able to, giving people enough time to live long enough to get dementia. Specifically, Alzheimer's disease is the most common kind of dementia, and we probably have the best statistics on that particular type because it is so common. At the current time, it's estimated that almost 6 million Americans have Alzheimer's disease, including a very small number under the age of 65. So it's not all older adults, although the vast majority are older. It's the sixth most common cause of death in the US, fifth for those who are 65 and older. And again, I do think we're seeing more dementia because people are living longer and not dying of other things first. And it's the only cause of death among the top 10 that can't be prevented, cured, or slowed. And I also want to just touch on suffering. I don't think we should conceptualize dementia as just suffering, but I do think I think it's important. Suffering is something that all humans undergo, and it's certainly true for people who have this illness as well as their families. And I think when we call it out and acknowledge it, it's part of seeing somebody as not just a demented person, but actually a person living with dementia who is still a person. And Keith Oliver was a fellow with early onset dementia, Alzheimer's disease. And there's actually a web page called the Dementia Diaries. He lived in the UK, and he collected recordings done by people who have dementia. And it's really very moving. And one of the things that he said, that information is really important, but not too much information. And the experience of the illness is more than just memory difficulties, which is a key point for dementia. I want to really encourage people to consider offering palliative care, or the approach of treating symptoms that are affecting quality of life right at the time of diagnosis. And I want to encourage early diagnosis, giving people enough time to actually look at their life, adjust things, plan for things, and discuss advanced directives and other things with their family and loved ones while they're still able. And this is really the model that we are encouraging with heart failure and chronic obstructive lung disease and cancer. And I think we should also start looking at dementia like that, because it really is a chronic illness. I think it's important that every time there's a medical event or a notable functional decline, we need to relook at the plan of care, individualize it, and focus on the quality of life. Make sure to educate the person and their family and supports about the disease progression. And as the disease progresses, I really would strongly consider referral to a hospice agency or a PACE, program of all-inclusive care for the elderly, or other palliative care program in the community. That will allow the best likelihood of the medical part of the health system focusing on quality of life rather than just quantity. And this really is the new paradigm. And traditionally, people think of palliative care really very much near the end of life. And certainly that is the last couple of weeks of a person's life. It is very important to focus on, symptom control. But there is so much more that palliative care has to offer if you start it much earlier. And one way to do that is to have triggers either in your electronic health record or in your protocol, or just sort of in the way you think about things. And so triggers they facilitate timely referral to palliative care. If they are built into your system, so when somebody has a diagnosis of dementia and you start to notice weight loss or other symptoms, that should remind you to offer palliative services to the person and their family. And that's what allows the identification of unmet needs, so that you can do the proper assessments and plan for goals of care. And so an example of triggers is cardiology. And so, we do that with the first hospitalization. We do that with the second hospitalization. And one of the things we educate people on is every time you have an exacerbation of your heart failure, the natural course of the illness is you do not recover to the same level you were previously. And we see a similar trajectory with dementia. People don't, they may get better after a deterioration, but they don't get well, and they don't get better than they were. There's just sort of a gradual decline in functioning. And we do the same thing with oncology. And one of the key triggers in oncology is the surprise question. Would you be surprised if this patient dies within the next year? And that's a great question. Doctors have a pretty good sense of that. And actually, that is one of the most valid and reliable questions to ask. And so that can be very helpful in helping to frame really where you are. For end-stage dementia, when we might want to look at that, the triggers for thinking about end of life in people who have dementia: frequent infections, people developing impaired motor functions or difficulty walking or moving, people becoming dependent on others for their activities of daily living, especially toileting, losing the ability to communicate or use words, difficulty swallowing and eating, weight loss, aspiration pneumonia, loss of facial expression, or the ability to smile. Those are all signs that somebody's dementia is really moving towards the end. You know, one study done in the Netherlands for a 10-year period followed people with dementia and really found that the three most common immediate causes of death were dehydration, severe malnutrition, cardiovascular disorders, and acute pulmonary diseases, mainly pneumonia, and especially aspiration pneumonia. The longer one lived, the more likely it was that you would die related to dehydration. But so whenever somebody who has dementia has any of these signs or symptoms or events, it really makes sense to think, you know, oh, we're at a new baseline. We're at a new part of the disease process. I'm going to switch gears a little bit. You know, these are common symptoms that we see in people who have dementia. They may be crying and look sad. They may be pacing and having psychomotor agitation. Clenched fists are not necessarily abnormal. Hitting and pushing caregivers away, calling out repetitively or screaming and being inconsolable. Those are pretty common symptoms. But besides thinking, oh, well, those symptoms are due to dementia, what I want you to think about is something different. I want you to think about pain. So, and this is the pain AD scale. And one of the key things to remember about people with dementia is that their verbal skills are not as good as they used to be. And sometimes they're, in fact, totally impaired. If they are talking, what they say may not at all be related to what they mean or what they're trying to communicate. And they may, in fact, not have very much language left at all. So how you know somebody is having pain, if they have advanced dementia, is through these nonverbal signs and symptoms. So breathing, negative vocalizations, facial expression, body language, and consolability. And a score of 5 or more on a pain AD suggests that somebody with dementia has pain. And this is somebody who you might say, are you in pain, Mrs. Smith? And they might say no. But if they are scoring on the pain AD scale, trust the scale rather than what people tell you, especially if they have any sort of health problem like arthritis or other things that are likely to cause pain. There are other tools out there. I happen to like the Pain AD because it has, it's highly reliable, valid, and frankly, I think it's fairly straightforward. I think people can understand it. There are really complicated screens out there if you wanted to go and look for them, and I have some listed on this slide. One of the reasons that it's really important to talk about adequate pain control is because it's not going to look the same in people with dementia as it looks in other people. People with dementia, again, they're not going to come up to you and they may come up and say, ow, or they may come up and say, I'm in pain. But it's much more likely that they're going to be doing those other things, pushing people away, pacing, psychomotor restlessness, crying, screaming. And one of the key things, just like in all the rest of us, whenever you're in pain, it makes many things about how your brain is working worse. So you can't really treat any other neuropsychiatric symptoms or behavioral symptoms related to dementia if somebody has untreated pain. They're not going to work until you treat the pain. So pain is something that one should always plan and focus on for somebody who has advanced dementia. And one of the key things to keep in mind is, we really, even people who know that there may be people in pain, if we don't make a regular practice of looking for the nonverbal signs and symptoms, it turns out we don't see it. We have to be alert to the sort of general conservativeness about treating pain in older adults. Back in the 60s, they didn't treat people who had advanced cancer with morphine or other pain medicines because they didn't want to kill them. Today, we would view that as medical neglect to treat people who were having pain, who are already dying, not to treat their pain. And I think the same thing is actually true about people with dementia, and I think we're not quite there yet. So I would encourage you to use validated tools routinely. And specifically in people with advanced dementia, what you're likely to see is this social withdrawal, depression, irritability, people limiting their movements, resulting in immobility and deconditioning, or alternatively, people being hyperactive and having pacing and severe psychomotor agitation. If we look at what the trajectory of end of life in common terminal illnesses is, the typical model we think about is we're all going through life and we hope we have just a very short, severe illness and don't suffer very much and die. That's sort of the ideal that many of us have in mind, if we even think about it. The trajectory in the middle there is what you see with heart failure and lung failure, or COPD, chronic obstructive lung disease. People, every time they have an acute decline, they may recover from that decline, but they never get back to where they were. And what you see in heart failure and lung failure is repeated hospitalizations, and the person just loses more and more functioning over time. With people who are quite old and physically frail, or people who have dementia, what we actually tend to see more often is just this slow, prolonged dwindling. And the number one barrier to referring people with dementia to hospice is difficulty assessing prognosis. And part of that is difficulty assessing dementia early, and part of that is difficulty really having a good sense of, how do I know if this person with dementia is near the end of life? Palliative care delivered in primary care often is a better fit and causes less quality of life distress to people with advanced dementia, but you need a primary care medical home or a primary care practice where there are staff who are familiar with pain and symptom control in people with advanced dementia. The National Hospice Organization uses the FAST scale, for enrolling people into hospice who have advanced dementia. The challenge is that that scale wasn't derived actually from studying people with dementia, and it doesn't apply to the majority of people. If you score high on a FAST score, where low scores are far from death and higher scores are near to death, you know, it could be a good scale. If you get to stage 7C is where you would be eligible for hospice services because of your dementia. That's if a person is unable to walk without assistance. But the challenge is, of course, if you can't walk because your dementia is so severe and your brain isn't working enough to help you get up out of bed and move, that's one thing. But there's a lot of other reasons why you might not be able to walk. You could have bad arthritis. You could have had a fracture. You could have back problems. You could have balance problems. So there are many reasons you might be unable to walk. So if you haven't gone through stages 7A, where you're using less than 6 meaningful words a day, and stage 7B, which is 1 or fewer words per day, to get to 7C, then it turns out that the FAST scale 7C by itself, without going through the progression, isn't very accurate. There's another tool that I suggest using that I think is much more accurate. It's the mini suffering state exam. I like it because it's relatively straightforward. It's 10 yes or no questions. And it really, some of the questions actually can help with the family grasping the bigger picture of what's happening with their loved one with dementia. So these are the first 5 questions: calm or not calm, screaming, pain. And so the pain AD is one way to measure that. If a person has decubitus ulcer or pressure injury, malnutrition, which you can see in lab work, although there are other ways to do it by physical exam. People who stop eating or aren't eating very much. People who with advanced dementia who are needing invasive action, frequent blood tests, catheterizations, either urinary or otherwise, IV fluids, transfusions, intubation. Unstable medical condition. Every time somebody with advanced dementia has an unstable medical condition, they are at very high risk of dying. And then the last 2 questions I think are the most important. One is, do you think the person is suffering? And that could be the physician or nurse practitioner or PA who's caring for the person, or it could be nursing staff in a facility. And then asking the family, do you think, you know, your mom, your dad, your spouse is suffering? And just the asking of that question, I have found, helps people move from their own grief at the loss of the person with dementia to being able to consider things a little bit more specific to the person. And if you score on a mini suffering state exam 7 or higher, that's a high level of suffering. 4 to 6 is intermediate. And it turns out that a score of 7 to 10 is consistent with needing, you know, with less than 6 months to live. So it's a pretty easy scale to use in primary care, and it is valid and reliable. And just the questions itself, I have found, helps families. So there was a project to integrate palliative care into primary care clinics. This happened at the Presbyterian Health System in New Mexico, and they wanted to improve access. They wanted to help primary care providers use palliative care with complex patients in their primary care medical home. So they looked at actually putting palliative care staff in the clinics. Of the people who were seen, they had 584 total visits, 253 unique people. The most common diagnoses where people were cared for by the palliative care team in the primary care medical home was dementia and debility or decline, as well as cancer patients who were not being cared for by oncology, who either were too sick to or didn't have an interest or desire to have interventions through their oncologist. And they looked at the quality outcome, and the patients expressed a significant sense of greater support. And when you looked at the data, the hospitalization cost dropped by 19%, ED use went down, outpatient service utilization went down. So moving on to psychiatric symptoms that are usually amenable to treatment with medication. So paranoia and delusions are pretty common. On any given day, 40% of people who have dementia will have paranoia or delusions. Hallucinations, 1 out of 3 people are likely to have on any given day who has dementia. Depression can be quite common if the depression is related to a depressive illness. You might want to treat it with a medication. However, sometimes people just start to talk about death because they're nearing the end of their life. Likewise with anxiety, if the anxiety is related to an underlying anxiety disorder, then it may very well respond to medications. But if it's not related to the underlying disorder, really consider, is this person nearing the end of life? Because severe anxiety that doesn't respond to anything is one of those things we often see as people progress. Pain often is responsive to medications. You really need to target your treatment to what kind of pain you think it is. And aggression. Aggression, if it's unprovoked, so it's not because you or somebody else went up to the person and got in their face or irritated them, but the aggression that sort of comes out of nowhere often is responsive to antipsychotics, although we don't know. It is hypothesized that many times those aggressive episodes are related to psychotic processes, but we just can't evaluate that because the person is nonverbal or not easily able to verbalize and answer questions. But if aggression is significant and not responsive to antipsychotics, really consider, is this terminal agitation? Is this a person who is nearing the end of their life? Whereas psychiatric symptoms that are not usually responsive to medications, there's no medicine to treat wandering. So if somebody is wandering, what you really need to do is work to make the environment around them safe. If somebody is calling out and it's not related to pain, you want to consider end of life. I just actually had a call yesterday about a patient who was calling out, ba, 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 quite loudly, sort of randomly throughout the day. And it was very disruptive to the adult foster home where this person was living. And so we were problem solving about that. And I asked the PCP, have you checked their ears? Is part of the reason they're so loud because they can't hear themselves. So make sure their ears aren't plugged up with wax. And I suggested a pocket talker. And so the PCP said, well, they've seen speech therapy and I said, no, not to communicate with the person, but a pocket talker, which is a device that amplifies noise, and there's headphones for the person to hear themselves. So if you put the headphones on the person who's screaming and calling out, and they can actually hear themselves, often that will help a person get quieter and not be as loud. If people have repetitive questions, there's not a medicine in the world that can treat that. That's usually because the person doesn't remember that they just asked that question. And so as hard as it is to hear the same question and to answer the same question dozens of times in the same day, the reality is for the person with dementia, it's the first time they've ever asked it. So trying to figure out a way to answer it as if it's the first time you heard it is much more effective than trying to find a medicine for it, because it's not gonna respond to medications. Likewise, anxiety related to having memory loss, anxiety about real things, isn't treatable with a medicine because it's not an anxiety disorder. It's a natural, understandable reaction to reality. So, comforting a person is much more effective than using a medication. Psychomotor agitation, again, first consider pain, treat it as if it's pain. And if it doesn't respond, then really look, is this person nearing the end of life? Sleep problems. Sleep problems for people with dementia often are because the part of the brain that controls sleep, that tells us when to go to sleep and when to wake up, that part of the brain has died. And so like sleeping pills, quote unquote, don't actually tend to help people with moderate to severe dementia. Sometimes in early dementia they can help, but they're still not a great answer. A much better answer would be if the person is physically able to walk around and get some exercise early in the day, increasing access to natural daylight in the early morning helps the circadian rhythm. If that part of the brain is still alive, it helps it work right. I have prescribed medications for sleep as well as the next person, but it just doesn't tend to work for people with advanced dementia. I do want to just touch on dementia-specific medications, and I just got this question again today. A lot of people are under the impression that dementia-specific medicines like Aricept, donepezil, Exelon or rivastigmine, galantamine, that those medications don't do anything to help with dementia. There actually is some evidence that they may slow functional decline a little bit. There is some evidence that they may slow cognitive decline a little bit, but functional decline and cognitive decline are still going to go on. There are no medicines to stop the advance of the illness. But it turns out that these medications actually are very effective at treating people who are having neuropsychiatric symptoms or behavior disorder related to their dementia. So I really think of dementia-specific medications as behavioral medicines rather than cognitive medications. And so specific symptoms that they've been found to help, so the cholinesterase inhibitors have been shown to effectively treat psychosis, agitation, paranoia, delusions, apathy, and depression. Memantine, there's some evidence that it helps with sleep and appetite. There's more evidence that it helps with anxiety, agitation, and aggression. One of the contraindications to the cholinesterase inhibitors is bradycardia, or a slow heart rate. That's probably the main contraindication. Sometimes people do have GI side effects with those medications, stomach upset or nausea, vomiting, or diarrhea. It turns out if you start people on memantine first and then add in a cholinesterase inhibitor, people are much less likely to experience the GI side effects because of the serotonin effects that memantine has. With memantine, the side effects that you want to be aware of, it can cause Stevens-Johnson syndrome, which is a very specific kind of very severe rash that can cause lesions inside your mouth, in your mucous membranes. And that is a very severe, there's nothing subtle about it when it happens, but if somebody is on memantine, starts new on it, and develops a severe rash, you definitely want to get them medical care right away. That's extremely rare, but it's the most dangerous thing. The other common symptom I've seen with memantine is lower extremity edema, and it can be really severe. So sometimes you have to reduce the dose because of that. So one of the most common kind of problems or challenges that we hear about for people with dementia is aggression. And what I think the key thing is to look at, when is the aggression occurring? You want to look at antecedents, or what was happening in the environment before the person becomes aggressive. There was a study done in Norway, and what they found was that there were almost all of the aggression happened at two different times. One was when you told someone no, or you took something away from someone, and the other one was with personal cares, when you were taking their clothes off or touching private parts of their body. And those two times make quite a bit of sense. If you are already confused and having trouble sorting out what's going on in the environment, if somebody tells you no, or steals something from you, right? They're taking something away from you. Most of us would consider that stealing. Or if somebody's trying to assault you by taking your clothes off, that can be very frightening. So in those kind of instances, the aggression is really tends to be self-protective. And so it's very key to look at different ways of approach. So caregiver training is the key thing for both of those situations. Often if you needed to take something away, say somebody in a dementia unit, memory care unit, takes something from a peer, rather than just going in and taking it away from them, taking it out of their hand, for instance, it's much better to have one person distract them and get them in a different room, and then just remove the object rather than physically trying to take it away from them. With personal cares, there's Bathing Without a Battle is a great book, and there are training tapes for that. There are many different, Teepa Snow has training for that. There's a book that I co-edited with Sarah Foydell, an occupational therapist, and that has an entire chapter on personal cares and how to help train staff different approaches for that. Specifically on this unit in Norway, what they found out was, 32 out of 82 people were labeled as violent on their dementia unit, but the vast majority of those incidences that were being described as aggressive and violent, there were almost no injuries, and the majority of the incidents were by a minority of residents. And it turned out that the most frequent intervention to defuse the situation was talking with the person. But that doesn't mean talking about, what's actually going on. A much more common and successful intervention is to talk with the person about something that they like, talk to the person, distract them. One of the most effective interventions I ever saw was we had someone who thought his car was stolen. He didn't know he was in the hospital. He thought he was at the mall, and he didn't have a car out there in the parking lot, but he thought his car had been stolen. And so he was getting himself all worked up and becoming angrier and angrier. He started pounding on the table. He started yelling loudly. And, the first thing that staff tried to do was tell him, well, Fred, you don't have a car here. And that didn't help because Fred knew he'd had his car there and he knew it had been stolen. So then he thought people were sort of in cahoots with the thieves. And so that wasn't helpful. But one of the staff members went around the corner and called the phone that was nearest to Fred and said, put Fred on the phone. And so somebody turned to Fred and said, Fred, there's a phone call here for you. It's about your car. So Fred took the phone and the staff member on the other line said, yeah, this is Jan calling from the local station here. I understand that you have a car that's been stolen and I want to get the information about that so I can make a report to the proper authorities. And so then she started asking Fred about his car. What was the make? What was the model? What was the color? How old was it? How many miles did it have? So she just went on and on and on asking him questions about the car. And finally he holds the phone away from his head and he looks at it and he says, this lady is just crazy. What does she want? And he hung up the phone and walked away. And I walked up to him and I said, hey, Fred, it's dinner time. Let's go have some dinner. And he said, oh, good. And he just walked away. So that's the kind of talking to the person. So not reality orienting him to something that he couldn't understand, but really entering the universe he was in and then shifting his attention in a way that diffused the situation. I do want to just touch on, there's a lot of controversy and a lot of misunderstanding about the use of antipsychotics in people who have dementia. There is a free guideline. It's 198 pages, but it is available online. It's the American Psychiatric Association practice guideline on the use of antipsychotics to treat agitation or psychosis in patients with dementia. And I can summarize the evidence base in that guideline, or you can download it and read it for yourself. But it turns out currently we have good evidence for treating psychosis in people with dementia for the use of risperidone and aripiprazole. As far as agitation and aggression, there's good evidence for risperidone and olanzapine. So those are doesn't mean that those are the only antipsychotics that would work, but those are the ones with good evidence. And I would put a little caveat in there. The most commonly used antipsychotic for people who have dementia is Seroquel or quetiapine, and that particular medicine is not very effective at all unless you happen to have Parkinson's disease or Lewy body dementia. But if you have any other type of dementia and you have psychosis, agitation, or aggression, quetiapine is not going to be helpful for those symptoms. And one of the things that people always talk about is if you put somebody on a medicine, when can you stop it or when should you stop it? And what I want to say is one of the things we know is that if somebody has psychosis or aggression and they have responded to a medication, they are quite at high risk of relapse if you discontinue that medication too quickly. And there was a very thorough study by Devenant published in 2012 that actually looked exactly at this specific issue. And what my guidance to prescribers is that it depends on the severity, right? If this was somebody who had once a week, mild to moderate agitation, aggression, or paranoia, then I think, treating someone for 4 to 6 months and then a very slow taper off is very reasonable. But if this is somebody who had life-threatening aggression, this is somebody who put a pillow over top of a roommate or tried to strangle their wife, or somebody who caused a fracture in somebody else, if they're not having side effects to the medication, my general recommendation is usually to continue it unless there's a problem. So I think you really do have to take the past history into account, as well as the person's current status. I mean, if a person becomes very weak so that they're at low risk of injuring someone else, and they are not having psychosis that is causing them suffering, you know, if you are fearful that somebody's trying to hurt you or kill you or people you love, it's only natural to be pretty frightened, and that's a pretty distressing circumstance. And so I think people should be treated for sure in that situation if it's causing them distress. But otherwise, you know, sometimes if it's related to agitation or aggression and a person is at a spot where they physically are not a risk to others, then I think it's a lower risk situation to try and taper someone off. So I just want to tell one short story here about Ruby. She is a 78-year-old lady who was sitting in a wheelchair with her guardian in my office. She was confused, oriented to herself. She could have a really good social conversation, and if you didn't know anything about her and your conversation was just, you know, about the weather and what she ate and that kind of thing, and it was very short, you might not even know that she was very impaired. But she was very impaired. And while we were talking, the guardian mentioned that, you know, she'd had several hospitalizations recently. And I said, oh, really? And so I started asking some questions, and it turned out, you know, she had multiple symptoms. And so I said to the guardian, you know, I think we should do a mini suffering state exam. So I pulled that up and I scored it with her, and she scored a 7. And I said to the guardian, you know, you might want to talk to her family. She is nearing the end of her life. I don't want you to be surprised. The guardian was astonished that I said that, because Ruby was still verbal and could still have a conversation, even though it might be repetitive. But she really was nearing the end of her life. And I got a phone call from the guardian about 4.5 months later to tell me that Ruby had in fact died. And if I hadn't had that conversation with the guardian, she wouldn't have been prepared, nor would she have been able to prepare the family for what was coming. So in sum, you know, dementia is a progressive terminal illness. I am a big fan of considering palliative care at the time of diagnosis, a focus on symptoms that are impairing quality of life, and targeting all of your interventions, both medications as well as other interventions, at quality of life support. If you can use a palliative care conceptual framework and honest communication, you're actually able usually to help a family and a person move through the process with clarity and with the ability to make the best choices possible. It's always important to treat the person and not just the symptom. And many of us believe that quality of life really includes engagement in meaningful activity, connection with other humans or other mammals, and pain control. And here are some references. So that is my presentation. Are there any questions, or I could keep talking?
Well, we have a rather small group today. And in the 6 minutes that we have left, this would be a great time to unmute and share a question, and let Dr. Nash, you know, really give you something that you can't get out of a textbook. get it from the horse's mouth. Sorry, that was a terrible analogy. Okay, folks, help me out. I'm talking. There's nothing that says we have to go all the way to 1 o'clock, but at the same time, 5 minutes with Dr. Nash is gold. Nobody has questions about medications. Nobody has questions about behavioral interventions.
Well, I do see that Nancy T wondered about receiving an email with the PowerPoint. Nancy,
Yes, and the message to the group is that yes, you will get your PowerPoint hopefully by the end of today. We want to honor the fact that you all carved out an hour to be here, and we want to again say thank you. Since we're not going to be able to send out an audio at this point, we want you to have those PowerPoints. So Pamela, it looks like you've unmuted, and I'm wondering if you would like to ask a question?
I do appreciate that. Can you hear me?
Yes.
Okay, great. I just want to thank Dr. Nash so much. I actually entered late, unfortunately, but have been taking copious notes. I'm a nurse working in geriatrics and doing medication management for several clients. This has been extremely helpful, and I will look forward to the PowerPoint. Any other resources that you can recommend that you have either published or that you would recommend for medication management, all of the topics that you've talked about? Maybe the PowerPoint is going to give us essentially what I'm asking. But.
So the PowerPoint does have a lot of information, and I would say there is a textbook, Neurocognitive Behavioral Disorders, an Interdisciplinary Approach to Patient-Centered Care. Was just published about a month and a half ago. I co-edited that with Sarah Feudel, who is a occupational therapist, and then Sue Rose, who's a PMHNP psychiatric nurse practitioner, also wrote several chapters in that textbook, and it's full of really very practical assessment and care planning information, as well as information on how to teach others to do ADL care for people in a person-centered way. So there's that. I think that there certainly are resources online, and I think there's a set of videos and they're all about the message, capital M, capital E, capital S, capital S, capital A, capital G, capital E, message. And it's an acronym. And I think they were actually done like in Australia or somewhere where they have one of those nice accents. But those videos, you can get them on YouTube, and they have a series of videos that are really just very useful for direct caregiving staff or for families on how to simplify what you're trying to communicate. And I think those videos are done, they're really the best videos I think I've ever seen on the topic. I don't think I actually have that reference in the PowerPoint, but you can, if you just go to YouTube and put in, message in all caps and, dementia, caregiving or something like that. That's how I found them. So if I could do it, they can't be hard to find.
Okay, I appreciate that. And one last quick question. The mini suffering state exam, is that in the PowerPoint as well? Or would I?
Yep, it is. There have been 3 or 4, actually, I think there have been about 8 different papers written on it. There are several referenced in the references, and the mini suffering state exam itself is literally on those 2 slides. It's just those 10 questions.
Okay.
Yes or no, and you just add it up.
Great. Okay, thank you very much. Appreciate all your help.
You're welcome.